Good evening, everyone. Welcome to the IPNA endorsed Webmaster Series 2021. It is an exclusive Glomerular Disease Symposium. And from today on, we are starting our polling sessions. And this series would be spanning till July 14th. The first talk is by Dr. Hanif. Dr. Mohammed Hanif is a senior professor of pediatric nephrology at Bangladesh Institute of Child Health, and his research interest is towards AKI, hypertension, nephrotic syndrome, CKD, genetic anomaly related to kidney disease. And he has got various publications, and he has authored many chapters in textbook. He has authored more than 100 articles in national peer-reviewed journals, and he has a prestigious post, Counselor of Executive Committee in Asian Society of Pediatric Nephrology, and he has been awarded as a Rotary Seed Award for the year 2002 to 2003, which was given for his outstanding contribution to the development of pediatric nephrology in Bangladesh and detection of adulteration in paracetamol syrup. Now I request Dr. Hanif to give his talk on clinical approach to a child with glomerular disease. Over to Dr. Hanif.
Thank you very much. I couldn't see this slide. Thank you very much, Dr. Kalra, for nice introduction. Thanks to the good evening to everybody. I thanks to the organizer, particularly Dr. Kalra, and also Namarwal, and I thanks to the organizer, particularly Dr. Mehta's Hospital, Indian Society of Pediatric Nephrology, and Indian Pediatric Association and IPNA for starting this tremendous, very helpful continuous medical education. Is not only helping the India student, but also the part of the in this subcontinent. Really is a good start. So how to get this slide? Can I have this slide? Oh, sorry for inconvenience. I will discuss about the clinical approach as child with glomerular disease. So, you know, it is one of the common disease. Glomerular disease is one of the common problem in pediatric age group. And so it's very important to know about this disease. I will a little bit discuss about some of the introduction and pathophysiology, because pathophysiology is very important, particularly for all disease. And if we know the pathophysiology, you can now the disease, we can know the if you know the pathophysiology, we can know the disease process itself, what is the clinical finding, what should be subsequent conditions, and what should be treatment. So it's very important, and some of the clinical approach. So in glomerulonephritis, what's happened, there is inflammation which causes neuron impairment, particularly and one of the important cause of end-stage renal disease in USA, about 10 to 15% cases. What's happened, there is a immune-mediated damage to the glomerular basement membrane, the mesangium, and the capillary endothelium, leading to the inflammation. This inflammation is the result of hematuria, hematuria, proteinuria, and azotemia. Difficult finding is hematuria, fluid overloaded, edema, and hypertension. There is evidence of renal insufficiency, already mentioned. And next is the so what's happened in pathophysiology? There is an antibody deposition into the antigen-antibody reaction, and it's deposited in the kidney glomerulus. Associated, there is activation of the complement activations, genetic factor, and along with this, there is activation of the hemodynamics factor. We know that there is when more pressure is rises, there is changes in the glomerular capillary, and also there is associated with the coagulation factor, leukocyte, with coagulation factor. There is tremendous amount of glomerular inflammation, and as a result of inflammation, the whole things happen. There is a hematuria, proteinuria, and after inflammation, two things could be happen. One is the exit of inflammation molecule. When there is a mild inflammation, there may be exit of inflammation resulting in resolution of the symptoms or resolution of the disease process. But when this inflammation is persisting, there is subsequently there is a formation of the scar, and there is ultimately end-stage kidney disease. And next, this is a study in the globally. There is a study from the Singapore. They have mentioned about that the total disease pattern of the glomerular disease is changing trend because of genetic factor, environmental factor, socioeconomic factor. So what's happened in the hematuria and proteinuria is decreasing in number, and more nephrotic patient and more chronic renal failure patient, they are increasing. This is the study for 4 decades with more than 3,200 student participants. And next is the approach to the different diagnosis of the serum level of the complement factors. We notice along with one of the important findings is that there is a complement activation, there is the immunoglobulin development of the antibody and activation of the complement. So it has a relation with the glomerular disease. When C3 and C4 above the reference level, there is every possibility minimal disease, focal FSGS, membranous nephropathy, IgA nephropathy, unassociated vasculitis, or glomerular disease with organized deposit. And if predominantly low C3, C4, predominant low with variable C3, there is a possibility of the cryoglobulinemia. And predominantly low C3 with variable C4, there is the atypical uremic, hemolytic uremic syndrome, C3 glomerulopathy, membranous polypoidal glomerulonephritis. And low C3, C4, acute post-infectious glomerulonephritis, infectious-associated glomerulonephritis, and polypoidal lupus nephritis. So I'll discuss about some of the case scenario. This case scenario, this is the scenario typically parents they come with. In first one, the 6-year-old child presented with the high colored urine, puffy face, headache, and weakness. Actually, most of the mother they come with the sometimes with the bottles like that Coke bottle containing this urine. They just look, my son or daughter having the urine like this. So that we initially present, and most of the disease is because of post-strokal glomerulonephritis. Then another case is the 7-year-old girl has presented with palpable rash over the lower extremity, abdominal pain, joint pain. Her routine investigation showed hematuria and proteinuria. And if you look at this picture, there is a palpable rash and also some of the swelling on the left leg. So this is a typical picture of the Henoch-Schulin purpura. Then this is another lady. This is 12-year-old girl has presented with the pain in the extremity with the rash over the face. On examination, she was hypertensive, palpable liver, spleen, hematuria, and heavy proteinuria. So in these cases, there is a multiple organ involvement too. This is possibly lupus nephritis. This is another case, 4th case. This was admitted 7 years back in my hospitals. This girl, 12-year-old girl, was presented with the hematuria and proteinuria with upper respiratory tract infection. And initially we thought it is some form of glomerulonephritis, so initial investigation was sent. On 3rd day, she, the poly hospitalized, she was complaining of the blood stain sputum. And we sent the all investigation, including lupus serology, including ANCA test, and it was found that the ANCA test was positive. So there is every possibility this is a case of vasculitis. So we'll discuss about some of the clinical presentation of the acute post-strokal glomerulonephritis. Most of the cases they presented with the hematuria and associated with proteinuria. There is edema, hypertension, and mild to moderate renal insufficiency. And in case of we know that most of the cases in post-strokal glomerulonephritis, there is a throat infections, and this occurs 1 to 2 weeks after throat infection. But when there is a skin infection on pyoderma, it's occurred within 3 to 6 weeks of infections. And this gross hematuria resolved within 2 weeks, and urine is smoky, is also gradually disappeared, and oliguria should improve within a week, and edema subside. Some of these patients may present it with the severe form of the cardiac decompensate or the encephalopathy. So we'll evaluate doing some of the clinical, probably next speaker, she will speak more about this. So I'm not elaborating these things. There is urinary dysmorphic. One of the important findings is the presence of the RBC cast in the investigation. And another thing is that increased ASO anti-DNSB, particularly in pharyngitis, and anti-hyaluronidase and anti-DNSB in 80 to 90% of the skin infection. We know that there is a type of organism responsible in the streptococcal infection, particularly in case of pharyngitis, it is the 12 type, M type 12, and type 1, 2, and 4. And in case of skin infection, it is type 9. If you like, looking at the timeline of the ASPGN after infections, the C3 complement level, it's start lowering in the from the latent period before appearing the set and persist for about 2 to 6 weeks. And also hypertension, which is one of the important clinical findings, it should resolve within the within 2 weeks. But as Suprita is persisting, and hematuria, though there is a microhematuria and persisted for months and years, but macrohematuria is usually dissolved. If you look at the histopathology, this is one of the important things, because I want to mention about the histopathology. If you know about the histopathology, so we know about the disease of the some pathophysiology and some of the disease process. And here, if you look at the first slide, there is a extensive inflammation with exudation of the mesengium. And in the second slide, there is a, if you look at this, there is a typical picture of the stereostar sky, the deposition of the complement C3. There is also other deposition of the some small amount of IgG and IgM. And typical finding in the EM, if you look at this, there is subepithelial hump, which is the typical finding of the post-streptococcal glomerulonephritis. IgA nephropathy is one of the commonest causes of childhood nephritis and most commonly presented with the bloody urine that occurs 1 to 3 days after the onset of the upper respiratory tract infection. Urinalysis shows erythrocyte and mild proteinuria. Particularly, biopsy is confirmed the diagnosis. And it is most common in the Pacific region and 20 to 30% cases in Europe and 2 to 10% cases in North America. And about the pathophysiology of the IgA nephropathy, generally considered to be the immune complex mediated, or what's happened, there is a polymerized IgA which is deficient in the galactose that have a tendency to precipitate. And when there is a formation of the antibody against the virus, this can easily stick together and causes deposition and causes inflammation. Two interesting findings, not a disease restricted to the kidney, but IgA deposited in the unaffected skin, indicate systemic disorder. This is some research were finding that unaffected skin also shows some of the deposition of the IgA. And another interesting finding is that rapid disappearance of the glomerular IgA deposition is observed when kidney with IgA deposition are transplanted to patient without IgA nephropathy, indicate there is a systemic disease. If you look at this, this histopathological slide, and we find that in case of IgA nephropathy, there is a mesangial, in first slide, there is a mesangial proliferation with endocapillary hypercellularity. In second slide, immunofluorescence shows IgA deposition predominantly. And in third slide, EM, it shows in the mesengium there is a subendothelial mesengial deposition, and occasionally there are few of them there are subendothelial deposit. And IgA vasculitis nephritis, purpura and patency within lower limb, predominantly at along with that, one of the following, according to the arthritis, arthralgia, abdominal pain, histopathology demonstrating immunoglobulin A deposition and renal involvement. It according to the Euler or print to press classifications. And in these cases, they presented with the rash in 95 to 100% of cases, with abdominal pain and vomiting in 35 to 85% cases, joint pain, especially the knee and ankle joint, there is swelling, inflammation, and subcutaneous edema present in 20 to 50% cases. They may present with the scrotal edema, bloody stool, or intersubsection. If you look at the histopathology, then it shows light microscopy. There is a focal and segmental mesangial hypercellularity with associated capillary lumen leukocyte. If you look at this slide, you will find that there is an arrow. In front of the arrow, there is a leukocyte, staining of the leukocyte. And in immunofluorescence study, you will find granular staining of the IgA in the mesengium and segmentally in the capillary wall. So it is a mostly mesangial staining. So what's happened? There is a pathophysiologically what's happened? Immune complex by IgA with antigen exposure after infection deposited into the basal wall, skin, joint, kidney, GIT, and influx of the mediator with activation of the complement that's giving rise to this inflammation. Risk factor associated with the renal involvement in HSP. That is clinical risk factor if there is a persistent purpura or persistent GIT bleeding. And if you look at the gene biomarker, then associated with HLA, DR, B1, or other gene abnormality, and gene associated with the glycosylation of the immunoglobulin IgA, nitric acid coat synthesis polymorphism, and cytokine-mediated deposition in the neutrophil injury. What is the relation between the IgA and HSP? Morphologically, immunologically, there is similar. May persist to disease in the same family and clinical difference. And HSP in acute, mostly in acute condition, IgA sometimes in chronic conditions. And HSP in the more younger child, particularly 4 to 5 years old, are very specific age. And IgA nephropathy mostly in adult or young. Lupus nephritis. Lupus nephritis, what's happened is one of the multi-organ involvement. When glomerulonephritis, along with the, we have discussed with the presented the rash, they presented with the hematuria, along with the hematuria and proteinuria, they presented with the rash, typical rash, they presented with the organomegaly, they presented with the different organ involvement. Particularly two diseases very dangerous in case of lupus. One is when they presented with the convulsion or neurological sign, that is called cerebral lupus, or when they presented with the intestinal lupus. And I have seen one patient with intestinal lupus. This was, we have to put girls, she was an 8 years old girl on the TPN. So it's a multi-organ involvement. And here is the main defect is the defect in the complement factor C1q, which what's happened, C1q, it's removed the apoptotic material and the remnant from the body. But when there is an antibody against this C1q, cannot remove this substance, so there is a, in long term, there is a formation of the autoantibody and causes damage to the body. According to, and According to the WHO classification 1 and 2, this is a mesangial polypartic lupus. We don't usually act as a acute glomerulonephritis, but WHO 3, 4 are called lupus nephritis. Commonly, renal impairment is associated with the more aggressive class 4 diffuse polypartic glomerulonephritis. Mesangial and endocapillary hypercellularity affect 50% of the glomeruli. Necrosis and possibly quiescent formation and subendothelial deposit give thickened basement membrane with a wear loop appearance of the on light microscopy. If show extensive granular deposition of the that is whole panel deposition and with the complement in subendothelial and mesangial area. If you look at the criteria for the lupus, according to the ACR and Euler in 2019, there are some criteria that is constitutional, that is fever, cutaneous arthritis, neurologic serositis. Out of this criteria, when there is a 10 point, is indicate there is a lupus possibility of the lupus. In WHO classification, class 3, class 4, and in class 3 what session there is an active or inactive focal segmental all global endothelial extracapillary glomerulonephritis involving less than 50% of the glomeruli. And in case of type 4, there is an active or inactive diffuse segmental global endo and extracapillary glomerulonephritis involving 50% or more than 50% of the all glomeruli with subendothelial diffuse immune deposition, or with or without mesangial alteration is common. Shunt nephritis. We know that shunt in pediatric patients when they're having hydrocephalus, sometimes we need to put the shunt, and shunt is a foreign material, so there is every possibility of the colonization of the bacteria. When they develop infection for a long time, because in the bulb, the bacteria can colonize and persisting for a long time, and that gives rise to the nephritis. They're presented with the hematuria, proteinuria, but sometimes it's very difficult to, shunt nephritis is very rare, important infection, but it is an immune complex mediated glomerulonephritis. Most occurs in patients with chronically infected ventriculoarterial shunt. And the diagnosis of the shunt nephritis is challenging, and early diagnosis treatment initiated with antibiotic and shunt removal may be important. And there are two types of shunt, BP shunt, and that is ventriculoperitoneal, ventriculoarterial and shunt. They're presented with asymptomatic proteinuria or hematuria. They may have a nephrotic range proteinuria, fatigue, hypertension, recurrence episodes of gross hematuria. There may be, because bacteria in these cases with antibiotic they can change, and so they repeatedly presented with the recurrent hematuria. And azotemia, they may have presented with the renal failure. If you go for the investigation, they have some of the findings in low hemoglobin leukocytosis. And other important finding is that there is a cryoglobulinemia may be present, and there may be high rheumatoid factor and with ANCA positivity. Endocarditis. This is a bacterial endocarditis is 20 to 60 times common in hemodialysis patient than general population. So it is very common among the, because in CKD patient, they have a cardiac problem along with the persistently we have a device. So there is every possibility of the endocardial involvement secondary to infection. And it carries a risk of 50% mortalities. Three different types of kidney involvement. It can be embolic renal disease, or it can be immune complex mediated, or it can be interstitial nephritis because of in biopsy finding, there is a necrotizing and quiescenting glomerulonephritis, endocapillary glomerulonephritis in 37% cases, and prominent C3 deposition and immunoglobulin G deposition in 30% cases. Here also ANCA may be positive. And urine microscopy, there is a dysmorphic RBC and high level of the immune complex and rheumatoid factor positive in 70 to 80% cases. And histologically of the kidney biopsy, there is a focal proliferation of the glomerulonephritis with diffuse proliferation and increased cellularity of the mesangial and plus minus Kissen formation. Cryoglobulinemia. This is a immunoglobulin that precipitates in low temperature. Most of the cryoglobulin are polyclonal immunoglobulin complex, and nearly half are monoclonal. Cryoglobulin is defined as a condition in which plasma and serum protein of IgM precipitate when cool below the body temperature. This protein precipitate at 4 degrees centigrade and dissolve again in 37 degrees. These are the protein that reversibly precipitate or gel at 4 degrees centigrade. They can present it with the acrocyanosis, ischemic or hemorrhagic retinopathy, severe Raynaud phenomenon with digital alteration, livedo reticularis, purpura, and arterial thrombosis. Most of the cases, they are associated with the infection, particularly hepatitis is one of the important causes, hepatitis A, B, C, and EB virus, cytomegalovirus, adenovirus. Also in chikungunya, there is incidence of cryoglobulinemia in chikungunya patients, and also bacterial cause, particularly brucellosis is important, fungal, malaria parasite, particularly malaria and toxoplasmosis, and autoimmune disease, also vasculitis, lymphoproliferative disorder, renal disease is important etiological factor. C3 glomerulopathy. Old name is mesengoproliferative glomerulonephritis 1 and 3, and new name is C3 glomerulonephritis, and mesengoproliferative to all cases, dense deposit disease. What's happened in this classification based on two things. One is the immune complex and monoclonal immunoglobulin mediated mesengoproliferative glomerulonephritis. Another is the complement mediated. So basic thing is that one, there is a immune complex that is the mesengoproliferative glomerulonephritis, and when there is a complement mediated, this is the C3 glomerulopathy is the main reason. So this is the basic two difference. In dense deposit disease, there is a mutation in the genes complement factor A and complement factor related protein. And in mesengoproliferative glomerulonephritis and C3, heterogeneous with severe, several studies reporting the complement mutation. If you look at this, slide, we can see the difference. In the first upper portions, there is activation of the both complement and immunoglobulin, and this deposited in the basement membrane. And ultimately, in the second phase, there is inflammation with the involvement of the mononuclear cells, monocyte, and that's giving rise to the inflammation of the endothelial cell. And ultimately, in third slide, they are deposited in the basement membrane, causes inflammation and main change in the membrane. So C3 glomerulopathy, that is dense deposit, and C3 glomerulonephritis, high dense inflammatory intramembranes as round deposit in mesangium in many cases of the TBM, and Bowman's capsules may present in some segment only. So what's happened in C3GN? In the first slide, there is the immunofluorescent deposit of this C3 coarse staining. If you look at this coarse staining of the immunofluorescent, and also in the Bowman's capsule, there is a red arrow in the Bowman's capsules. And in the second one, in the upper portion, that is V, there is a predominant mesangial ring. If you look at the 706 and 7 o'clock position, you will find that there is a ring shape. In C slide, we'll find that there is a glomerular that is electron microscopy, glomerular capillary intermuscular dense material. This is typical of the C3 glomerulopathy. And in D, that is intense glomerular deposition and intermesangial glomerular membrane. In E, there is the intense granular deposition in the mesangium and also glomerular basement membrane. And in F, there is a subepithelial and mesangial. If you look at these two arrows, one is the red arrow, it is the subendothelial deposit, and another is a black arrow, is in the about 4 o'clock position. We can find that mesangial deposition of the immune complex. Uncaseated vasculitis. P-ANCA, P-ANCA is the antibody typically, and it's ANCA is antibody against the antigens in the cytoplasm of the nucleus. P-ANCA is the antibody typically directed against the myeloperoxidase, and C-ANCA antibody typically directed against proteinase 3. And titer of the ANCA does not correlate with the disease activity. And if you look at on the left side, there is a perinuclear staining, and on the right side there is cytoplasm stain. And some of the other diseases can give the ANCA positivity, like lupus, rheumatoid arthritis, ulcerative colitis, endocarditis, and some of the drugs like hydralazine. So there are 3 major types of ANCA. One is the microscopic polyangiitis. They presented with the renal involvement is a necrotizing glomerulonephritis is very common, and there is also pulmonary capillaritis, often with the pulmonary hemorrhage, and granulomatous inflammation is absent in case of microscopic polyangiitis. In case of granulomatosis polyangiitis, there is a extravascular granulomatous inflammation, most often in the upper and lower respiratory tract. Destructive sinuatrial nasal disease. There is a destructive lesion of the nose and upper respiratory tract, and necrotizing glomerulonephritis is common, and there is also pulmonary capillaritis. In eosinophilic glomerulomatosis polyangiitis, extravascular granulomatosis inflammation, as well as plaque, eosinophil, and asthma. Necrotizing glomerulonephritis is less common. And in this set, what is the pathology main is that there are the environmental factor and also genetic factor with the change in the HLA, DP, HLA, DQ, and environment. This activate the neutrophil with the activation of the ANCA and causes necrotizing lesion, inflammation, or granulomatous inflammation. Another important cause is the hemolytic uremic syndrome. It's very common. They presented with the triad syndrome. We know that, and in these cases, when there is the atypical cases, there is a mutation in the complement regulatory protein that is complement factor ACE, and also membrane cofactor protein and thrombomodulin, and or alternate complement pathway protein CA factor B complement lead to the dysregulation or increased activity C convertase, resultant to the degradation of the enzymatic acid. What's happened? Because of this regulatory mechanism abnormality, C3 convertase persisting, so there is a complement activation is persisting. So this inflammation is persisting. Also, there is a anti-factor ACE antibody. This anti-factor ACE antibody accelerates the clearance of the factor ACE. This leading to the result is that they can easily, because factor ACE is important particularly to maintain the integrity of the blood vessels. So because of this antibody formation, there is a increased number. If you look at the histologically, main hallmark is the capillary thrombosis with thickening of the endothelial swelling and deposition of the floccular material between the basement membrane and endothelium, and mesangiolisis. There is a platelet and fibrin-rich thrombi and fibrinoid necrosis. In immunofluorescence, there is the IgM and capillary deposition in the sclerosed area. Antiglomerular basement membrane disease is very rare in children. When antiglomerular basement disease is not rarely seen in the antiglomerular basement membrane is not common, and the disease can be life-threatening, so early diagnosis is important. Besides this, before going to finish my slide, I just want to share a few of the things. One, my experience, particularly in the messenger capillary glomerulonephritis, while I was working as a house job in doing the renal fellow in Australia, one day one of the patients referred from the other unit, and this girls of 8 years presented with the Hematuria, Proteinuria. Next morning, when I tried to evaluate the girls, I couldn't find any clue. Next morning, I was very puzzled, and the nurse who is working, next morning, she just passed me one literature. And I saw that there is a activation of the complement system in the lipodystrophy. So I started checking again this girl again. So I found that there is a lipodystrophy on the left-hand side of her health. So lipodystrophy is one of the important findings in particularly mesangial polyphytic glomerulonephritis. Before finishing, I just want to say this. I just try to mention about the pathophysiology because it's important. Most of the disease, this is related, and this is modified with the genetic factor, environmental, and another socio-economic factor. So disease process is also changing. So my take-home message is take-home message is renal biopsy is the key tool for the diagnosis, but not always. All the cases we need to go to the renal biopsy. But when you're facing the renal biopsy, you need to go to the renal biopsy. Biological approach incorporation with the molecular information, clinical, histological data will be helpful for comprehensive and precise classification of the glomerular disease that will exactly define disease, guide treatment, and predict long-term renal outcome. And environmental genetic factors are associated with immunological mechanisms, so further research is required in this field. So I'm sorry about my problem with my slide. I think I have to something overlap with the. I'm sorry about that.
No issues.
Much.
Thank you so much, sir. It was an excellent talk. Thank you so much for taking us through the journey of clinical approach to a child with glomerular disease. There are always technical glitches. That doesn't matter, sir. Thank you so much. And next on row is Dr. Supreeta Kaldra, who's the next speaker of the day. Dr. Supreeta Kaldra is a has done her fellowship in pediatric nephrology from AIIMS New Delhi and NUH Singapore. She is currently working at Army Hospital Research and Referral New Delhi. Her specialty towards pediatric nephrology teaching and learning, and towards nephrotic syndrome and Acute. And she has also received award for the World Kidney Day project in the year 2018 and 2021. Over to Dr. Supreeta Kaldra to deliver her talk on assessment of renal function test.
My slides, Dr. Kalaiwani. So thank you. Yeah. Yes. Can you hear me? Am I audible?
Yeah, I'm able to hear you. Yeah, you're very much audible.
Yes. Thank you. Thank you, Dr. Kalaiwani, Dr. Namalwar sir, and entire team to invite me for this IPNA teaching course. And I'm specifically very, very thankful because in these troubled times of pandemic, we are able to do some academics, some learning, again, connecting back to nephrology while we treat and do COVID duties day in and day out. My talk, Assessment of Renal Function in Glomerular Disease, is made much easier by Professor Hanif, who has spoken just before me and touched many important clinical aspects. I will try to focus more on how we assess a child whom we suspect a glomerular disease. And when do we suspect that, and how do we assess and evaluate these children? So let us look at this case scenario first. This is a 6-year-old boy who came with vomiting for 7 days, swelling all over the body, which had started on the face and decreased in urine output. The mother gave history of cola-colored urine, as in this bottle, for last 1 day. On examination, his blood pressure was very high. It was 160/92. He had stage 2 hypertension. His investigations showed grossly deranged urea and creatinine, a very high potassium, and urine RE and microscopy showed numerous RBCs, RBC cast, dysmorphic RBCs, and 3+ proteinuria. So how do we evaluate such children? How do we go on to decide what therapy and how much therapy will they need? This is what I would try to attempt to cover in my talk now. So what do children with glomerular disease present? So we must know that what are the historical features and what must we look on examination of these children before we decide on evaluating. So a good history it can never be overemphasized that a good history is always the key to diagnosis. So history of skin lesions or pharyngitis in last 2 to 4 weeks, even if mildly symptomatic, which the parents may have forgotten, so that history should be actively sought. History of noticing the color of urine, decreased urine output, swelling over the body. They are the characteristic features on examination and will be noticed by parents. Any history of skin rash, as we know, various diseases are characteristically associated with skin rash, like henoch-Schönlein purpura, now known as IgA-associated vasculitis, or SLE, and many others. If there has been vomiting or poor appetite, these symptoms, if present for a long time, may actually point out towards a chronic GN with deranged RFTs for some time. Headache, seizures, which may be because of hypertension. If there has been a recurrent history of worry or asthma-like symptoms, which may be seen in ANCA-associated vasculitis, especially eosinophilic vasculitis. Hearing loss, seen in Alport. Joint swellings, joint pain, again seen in IgA vasculitis or SLE. Pain abdomen, and whether there has been a family history of renal disorders similar to this child or different. So family history is also important. We examine the child in toto, but especially look at hypertension, edema. The skin examination is very important. Then examination of the joints, chest examination for V's and for Krebs if there may be features of pulmonary edema, hearing loss, and examination of the eye for lenticonus or fleck retinopathy, which are characteristic features of Alport. So here we go to these two diseases where the clinical examination gives us a fair idea. And in fact, these clinical signs are highly sensitive and specific of the diagnosis. Family history of Alport is very sensitive. Similarly, bilateral sensorineural hearing loss has very high sensitivity as well as moderate specificity. So unless we examine and take active history for hearing loss and eye examination and family history, we may miss the diagnosis of Alport syndrome and may be investigating the proteinuria on a wrong tangent. Similarly, in IgA vasculitis, these diagnostic criteria have already been spoken about by Professor Hanif, but presence of purpura or petechiae has extremely high sensitivity and specificity for henoch-Schönlein purpura and nephritis, and forms the most important mandatory criteria for diagnosis. So when we see a child with red urine, what are the steps that we need to take for such a child to confirm whether these symptoms are actually of glomerular origin or renal origin at all, or it may be because the child has taken some drugs or food dyes or food items with high carotene which are imparting a reddish-orange color to his urine. So red urine is not always hematuria. So first we rule out any history of drugs and food items which can give color to the urine. We perform a microscopy and urine dipstick. Urine dipstick we will be coming to that in more detail, but urine dipsticks are very sensitive and they rely on the peroxidase enzyme which converts the pigment and gives it color. So urine dipstick being positive shows that there is hemoglobin or myoglobin or RBCs in the urine, and that we need to confirm on microscopy. Presence of dysmorphic RBCs, RBC cast, and proteinuria leads us to a diagnosis of glomerular cause of nephritis. Whereas if the RBCs are present but not dysmorphic and there are no casts or other casts rather than RBC cast and little proteinuria or no proteinuria, we have to think of non-glomerular causes. So if there are glomerular causes, Dr. Hanif has already detailed us, given us quite a few investigations, but we will be coming to that subsequently, and we will also discuss when do we need a biopsy and when do we need an urgent biopsy, which is very important for the diagnosis and for the management of the child. So what are the causes of glomerular hematuria? It can be a post-infectious or infection-related glomerulonephritis. It can be present in various systemic infections, including malaria, leptospirosis, which are still common in the Indian subcontinent, and infective endocarditis. In IgA nephropathy, membranoproliferative glomerulonephritis, which may be immune complex, a C3GN or dense deposit disease. In SLE, ANCA-associated or ANCA-negative vasculitis, anti-GBM disease, in Alport syndrome and thin basement membrane, and sometimes in 20 to 30% of FSGS, that means children who present as nephrotic syndrome, may have microscopic hematuria. HUS is another cause of microscopic or gross hematuria rarely, but is not strictly a glomerulonephritis. These children, we already discussed, will have these features, characteristic features of normal colored urine in only pure microscopic hematuria or cola or tea-colored urine in gross hematuria. The RBCs will be present in the urine with dysmorphic RBCs and RBC casts being highly sensitive of glomerular causes. They also have proteinuria, which may be nephrotic to subnephrotic in range. So urine analysis is the most important investigation or the first step of evaluation in these children. And it has been rightly said that urine is the liquid biopsy, or actually the urine is the mirror of the kidneys. So there are certain prerequisites for urine analysis so that we are able to pick up the diagnosis completely and we do not miss out on something. The first morning sample is preferred, but a midstream clean catch any time of the day in office setting is important. Timed collections are required for biochemistry, including 24-hour collections for protein, and if not 24-hour, then 12 hours or even 6 hours, but the exact time and exact volume are important. Then we need to collect this sample through a urinary catheter. A midstream clean catch is possible only in toilet-trained children, and in newborns or very small infants, a suprapubic tap may also be required to collect the urinary sample. The urine containers for 24-hour collection should have adequate volume of at least 3 liters. And the analysis, this is most important, that we must insist to the lab that the urine analysis should be done as early as possible, preferably within 1 to 2 hours of collection. And the written instructions should be given to the parents before collection and explained to them in a language that they understand. We must also give written instructions in detail to the lab to what we are really looking at. Centrifugation of 10 ml aliquot of the urine and then resuspending it to examine for casts. gives a good is very important for detecting the urinary RBC casts, and phase contrast microscopy should be done for dysmorphic RBCs. We must correlate the clinical findings, the urinary and the biochemistry findings. So the urine analysis in so many terms will tell us whether the the hematuria has been microscopic or macroscopic. Sometimes it may be transient, and if children do not have other signs and symptoms, and if the proteinuria is very mild, then we may have to re-examine them in next 2 to 3 weeks to see whether it is persistent. However, gross hematuria along with proteinuria merits urgent, complete evaluation. In gross hematuria, we have already mentioned that the urine becomes cola color or tea color, that is reddish brown in glomerular causes, and they are usually concentrated because the GFR is low, so the specific gravity of the urine is high. Hematuria is present, has been defined by presence of more than 5 RBCs in a fresh uncentrifuged sample, or more than 3 RBCs per high power field in a centrifuge sample. Some books and some authors still believe that more than 5 RBCs in a centrifuge sample should be present to define hematuria. However, persistence of 2 or 3 RBCs have also been found to be significant. Microscopic hematuria in school children was found to be up to the tune of 0.41%. But when the more and more samples were analyzed, it was far less in percentage. And this is based on an old study because now routine urine analysis is not done in school children. And it is still practiced in some countries in Japan, like Japan, Taiwan, etc. So isolated microscopic hematuria merits at least 2 to 3 urine analysis over next 2 to 3 weeks. However, macroscopic hematuria with proteinuria merits urgent follow-up. And 4% of school children may have macroscopic hematuria with follow-up urine analysis normal. So we do need to evaluate these children carefully to decide that which subgroup of children will require further evaluation, will require urgent evaluation, and which children we just need to counsel the parents and follow up and do not need to do unnecessary detailed evaluations. Dipsticks have 100% sensitivity and almost 99% specificity for RBCs when at least 1 to 2 RBCs are present per high power field or 5 to 10 RBCs are present in 1 liter urine. So they are really sensitive and specific. Proteinuria with isolated microscopic hematuria may be present. If we say that this proteinuria is purely due to the RBCs in the urine, then it will be always less than 2+, that is less than 100 milligram per deciliter. But proteinuria more than 2+ or more than 100 milligram per deciliter indicates that there is definitely involvement of the glomeruli and needs to be evaluated. So dysmorphic RBCs can be seen by phase contrast microscopy as you see in these slides, and the dysmorphic RBCs are usually in form of these acanthocytes, which are ring-like RBCs with bleb-like structures on their surface, and they can also be seen in light microscopy with right stain. A dysmorphic RBC percentage of more than 20% suggests glomerular hematuria, and this has very high sensitivity and specificity. Presence of these acanthocytes, which we just discussed, are highly specific for glomerulonephritis. Presence of dysmorphic RBCs more than 25% and more than 10 RBCs per high power field predict GN to a very high percentage. And if you combine it with the proteinuria of nephrotic range proteinuria of 2 grams per day, then the sensitivity and the positive predictive value of these investigations is as high as 83%. It has also been shown in recent studies that patients with IgA nephropathy With microscopic hematuria, they are more likely to have more severe changes on biopsy, and increase in microscopic hematuria is significantly associated with increase in glomerular filtration rate decline. So talking a little bit of casts in urine, we just discussed that presence of RBC cast in urine is highly sensitive and specific for glomerulonephritis. Sometimes the RBC casts may be present mixed with WBC casts, which are usually seen otherwise isolated in pyelonephritis. Mixed casts can be seen, so therefore RBC and WBC casts both can be present, or pure RBC casts can be present in glomerulonephritis, and they are usually the fresh casts. Once there are granular casts, then we suspect that these casts may be from the tubule, and waxy casts are usually seen originating from the distal part of the tubule. Hyaline casts are actually most commonly seen, and they can be almost clubbed as labeled as physiological because they are formed from the protein, which is normally the tubular protein or the Tam-Harsfeld protein secreted by the tubules. So when we have been talking of proteinuria, but proteinuria also can be transient, orthostatic, or persistent. And it is the persistent or the massive proteinuria, that is the nephrotic range proteinuria, that we worry about the most. The incidence of proteinuria may be 10% up to 10% in school children, but its incidence comes down drastically to 0.1% on repeated testing. And this has been primarily because many children school children, especially above 7 to 8 years of age, can have orthostatic proteinuria, which means that they have proteinuria on walking around, but the early morning proteinuria will be less and will definitely not be in the nephrotic range. It will be less than 1+, trace to 1+. And they have normal urine protein creatinine ratio early mornings, but they may have a higher urine protein creatinine ratio once they are up and about walking around. So that is orthostatic proteinuria. The urine dipsticks that we usually use in our office practice, they are actually sensitive and they detect albuminuria, for which they have high specificity and sensitivity. They do not routinely detect or become positive with other tubular proteins, for which various other investigations are required. But since we are talking today of glomerular disease and assessment of a child with suspected glomerular disease, we will concentrate more on the glomerular proteinuria, which is more or less almost entirely formed by the albumin. So we know that the normal urine protein creatinine ratio is 0.2 milligram per milligram and is less than 0.5. When it is less than 0.5, it is called subnephrotic range, and more than 0.5 and more than 2 of urine protein creatinine would be definitely nephrotic range proteinuria. Between 0.5 to 2 would be the subnephrotic range proteinuria. So subnephrotic range proteinuria would require repeated analysis, whereas a nephrotic range proteinuria would require urgent complete evaluation and would show 3+ to 4+ on these urinary dipsticks. So why is this urine protein creatinine ratio so important? Because it is not possible and not easy to do time samples again and again in our office practice. And in children, collecting 12 to 24 hours urine becomes cumbersome, and many times incorrect volumes are reported. So this urine protein creatinine ratio done on a spot sample collected by a midstream catch in the office works very well, and it correlates very well with the time sample collections of more than 40 milligram per meter square per hour or 1000 milligram per meter square per day if the urine protein creatinine is equal to or more than 2. So let us look at a clinical approach to acute glomerulonephritis. so that we are able to talk of further evaluation of these children. So far, we have discussed that these children would characteristically present with hematuria. They may have edema and oliguria depending on how severe their GN is, and proteinuria. So when we confirm the urine findings of dysmorphic RBCs, RBC cast, and proteinuria, we are quite sure that we are dealing with a glomerular cause, and we need further investigations to decide what type of glomerular disease is this. If there is increasing creatinine rapidly over days to weeks, it may be a rapidly proliferative glomerulonephritis, which can have various causes. We will discuss that shortly. We need to assess the complement because in our current understanding, we classify and manage glomerulonephritis as hypocomplementic, complementemic, normocomplementemic, and low complement glomerulonephritis. And we know that the low complement glomerulonephritis may either be transient, that means the C3 complement and C4 is low for first 8 to 12 weeks and recovers. And this is classically seen in post-infectious glomerulonephritis. And there are conditions where the low C3 persists for a long time in C3GN and other membranoproliferative GN, including the immune complex GN and lupus nephritis. Also, the complement levels are normal in IgA nephropathy and ANCA-associated or ANCA-negative vasculitis. But whether they are low complement causes with low complement levels or normal complement levels, they can both progress to a rapidly progressive GN. So what are the other investigations that we need in a child with acute glomerulonephritis? We need complete blood counts with peripheral blood smear. This is essentially to rule out any causes of pancytopenia, thrombocytopenia, which histocytes point strongly towards hemolytic uremic syndrome. We need kidney function tests with urea and creatinine, ABG for metabolic acidosis and potassium levels to understand whether this child may require urgent renal replacement therapy, especially in children with rapidly proliferative glomerulonephritis. Then we talked of complement studies to know whether this is a normal complement level GN or a low complement level GN, and whether if complement levels are low and child appears to be following the post-infectious GN course, which is still the most common cause of glomerulonephritis in children, then we need to follow up a complement level after 8 to 12 weeks. We also need to do anti-nuclear antibodies and anti-DNA antibodies to rule out SLE, especially important if there are clinical features as discussed of SLE. P-ANCA and C-ANCA screening was earlier recommended strongly by immunofluorescence and later ELISA, but now with the availability of newer generation ELISAs, which are highly sensitive and specific for PR3 ANCA and myeloperoxidase ANCA, the immunofluorescence may not be required. However, P-ANCA and C-ANCA are required in children with glomerulonephritis. ASO titers and anti-DNase B titers help us in children to decide if these children had a streptococcal sore throat, pharyngitis, or skin infection. Anti-DNase B levels are far more sensitive for children who had skin involvement. Blood cultures, throat and skin swabs and cultures if any pus points are present, anti-DNA antibody, and hepatitis B and C serology for ruling out the hepatitis B and C as underlying cause. We also do a renal ultrasonography. In children with acute GN, it should show normal sized kidneys with raised echogenicity, which is usually reported as medical renal disease by our radiology colleagues. But in a child who is having raised echogenicity, evidence of GN with shrunken kidneys, we need to think of chronic GN and its causes. A chest radiography is required in children who may be having symptoms of vaginous, which point towards the vaginous granulomatosis, or in children who are suspected to have pulmonary edema. Echocardiography is required for the same reasons, but is not required in an urgently, because the urgent management becomes more important if child is already developing pulmonary edema, either due to hypertension or due to fluid overload. The additional investigations are available and required in specific cases, like in IgA-associated vasculitis. Skin biopsy from the purpura can give us diagnosis of the leukocytoclastic vasculitis. Anti-LAMP2 antibodies are also seen in some children who are ANCA negative, but they are POSI immune on biopsy. So these antibodies we can study. Similarly, anti-GBM antibodies, when it is the anti-GBM, the GBM is what is primarily involved in a child who undergoes biopsy. Then other testing for antibodies like anti-phospholipase 2 receptor antibodies and thrombospodin domain like domain 7A autoantibodies in children with membranous nephropathy, though it is very rare in children and far more common in adults. In a child with C3GN, molecular testing for C3, CD46, complement factor B, H, and genetic testing is available and should be resorted to. Genetic testing is also required for confirmation of diagnosis in children with hereditary disorders like Alport syndrome. Various autoantibodies, including C3nef, C4nef, though not easily available, should be tried if we suspect a cause or if we suspect a child to have C3GN, because these are important for prognosis as well as taking many management decisions in these children. So just briefly, mechanism of primary glomerular injury, which helps us decide how this child, what this child's biopsy will show us, and somehow it is very, very strongly correlated with the prognosis of these children. So it can be an immune complex disease, and these immune complexes can be either circulating or they may be in situ formation of immune complexes seen in post-infectious GN, IgA nephropathy, lupus nephritis, and immune complex MPGN. Then post-immune mechanism of injury seen in ANCA-associated vasculitis and ANCA-negative vasculitis, which may have antibodies against the LAMP2 that we just discussed, and anti-glomerular basement antibody seen in anti-glomerular basement antibody disease, also known as Goodpasture syndrome. The classification of GN has been recently proposed by the Mayo Clinic and taken up by the Renal Pathology Society consensus published in JASN in 2016. And they said that we can identify two more patterns if we take the pathogenic types and try to correlate it clinically. So the immune complex, the POSI immune and anti-GBM disease that we just discussed, they have also described C3GN to be a separate entity, and it is definitely required since they behave entirely differently from the membranoproliferative GN due to the immune complex type. So they are an entirely different subtype, and dense deposit disease is another entirely different subtype. Monoclonal immunoglobulin glomerulonephritis, far more common in adults, has also been put as a different subtype. So this we have discussed that the disease can be either hypocomplementemic or thrombocomplementemic with different causes as already discussed, and both can progress to rapidly proliferative glomerulonephritis. And their main pathogenesis will be immune complex deposition in the hypocomplementic disease with dysregulation of the alternate complement pathway in C3GN, and normocomplementic glomerulonephritis, depending on the deposits that we see or depending on the underlying pathology. In IgA nephritis, it will be abnormally glycosylated IgA deposition. It can be the In membranous, it can be the autoantibodies, which can be seen in the serum also and on biopsy. And in ANCA-associated vasculitis, we can do the ANCA levels, the P-ANCA and the C-ANCA. So what are the indications of renal biopsy? At presentation, if there are features of systemic illness in form of fever, joint pain, skin rash, then definitely it is an indication for biopsy. If there has been an absence of serological evidence of streptococcal infection, this was very important a few years ago when most of the cases of post-infectious GN were due to post-streptococcal infection, but it is not so evident now. But definitely if the C3 is not low at presentation, then we need to think of biopsy early. A rapidly progressive glomerulonephritis, we need to do a biopsy upfront as soon as feasible. When the child is too unstable, treatment in form of early immunosuppression, 1 or 2 pulses of methylpred and renal replacement may be required to be given before the child is stable enough for biopsy, but it has to be done urgently. And unexplained acute or rapidly progressive renal failure merits an urgent biopsy. When there is delayed resolution of features, that means if there is persistence of oliguria, hypertension more than stage 2, or derangement of renal function for more than 1 week or 7 to 10 days, we need to think of biopsy. A nephrotic range proteinuria persisting for more than 2 weeks or persistent subnephrotic proteinuria more than 6 months, low C3 beyond 8 to 12 weeks, and gross hematuria beyond 4 weeks or microscopic hematuria persisting after an episode of GN for more than a year. They are the indications where biopsy is required. And some prerequisites of biopsy, we know that we all perform biopsies in a prone position. Rarely a supine anterolateral position is required when the patient has very lot of edema or there are other reasons of respiratory compromise. We prefer ultrasound guided biopsies in all cases. Rarely CT guided, laparoscopic or transjugular biopsy may also have to be resorted. This is mostly done in very obese adults, rarely ever required in children. The prerequisite is that the platelet counts should be normal. The PT-INR should be normal. We prefer and we must take 3 cores of the biopsy using an automated gun and send the biggest or the best core for light microscopy and fix it and send it to the lab in 10% formalin. The immunofluorescence can be sent in Michel's fixative or even normal saline if the lab is in the same hospital, same institute, and it is going to be fixed very early in next 1 or 2 hours by the lab. The electron microscopy sample needs to be sent in 2 to 3% glutaraldehyde. It is a very good idea to use a dissecting microscope in the room that you're in, your biopsy room, in your procedure room, to determine if the core taken is adequate. And sometimes you can, instead of using the dissecting microscope, you can use a normal microscope and the core can be just seen in saline to see if glomuli are there or not. Otherwise, you will have to repeat the process again, and it's definitely not easy or feasible in children. So we know the common stains that are used on kidney biopsy are hematoxylin and eosin, which gives a general characteristic of the cells and the tubules, but we require pass staining to differentiate the glomerular and tubular cell membrane, the basement membrane, and the mesangium. Silver methamine stains are usually used for further detail as well as Mason's tricone. Electron microscopy gives us details of not only the glomerular basement membrane, it is being used for the details of glomerular basement membrane and presence and location of the immune complex deposits, whether they are subepithelial, subendothelial, or intramembranous, which are very, very crucial for diagnosing a glomerulonephritis correctly, and which also will further decide our management. Post-biopsy monitoring for urine naked eye examination is important for gross hematuria. Hourly pulse and blood pressure should be monitored for 4 to 6 hours to pick up if there has been any post-biopsy bleeding from the biopsy site. Immediately doing an ultrasound after you finish the biopsy is a good idea to make out if there is a hematoma around the kidney, which indicates post-biopsy bleed. Absolute contraindications for biopsy would be if there are small shrunken kidneys, because there we do end up having massive bleeding, which can be life-threatening, which may require nephrectomy or embolization. Abnormal coagulogram is definitely a contraindication and should be first addressed before a biopsy can be planned. Uncontrolled hypertension is another contraindication. Relative contraindications include a solitary kidney, an uncooperative patient, and patients who are unable to lie flat on bed, maybe because of edema. So this we have already discussed. I'm sorry, it's a repeat slide. So we discussed briefly the role of electron microscopy, and we just discussed that it is very important for making the correct diagnosis. And in a recent study, it was found that electron microscopy was crucial in more than 1/3 of the cases where the final pathological diagnosis would have been incorrect if electron microscopy had not been resorted to. And it was especially critical in the diagnosis of cases including minimal chain disease, Alport syndrome, thin basement membrane disease, and Fabry disease in up to 173 of the 855 cases where only LM and IF would not have given the correct diagnosis. Similarly, even when LM and IF were suggestive, electron microscopy was essential to clinch the diagnosis in 59 cases, including early membranous nephropathy, PIGN, dense deposit disease, and TMA. So this is a very important paper, and it tells us that even if we do not have the facility of electron microscopy in our institute, we must make all efforts to get the electron microscopy in wherever possible and convince the parents to get it done, even if it means extra payment or increases the cost of the biopsy, because it is very crucial in coming to the correct final diagnosis, which would then define and dictate our management. So a word about the rapidly progressive glomerulonephritis, which is a clinical syndrome of GN with progressive loss of kidney function. And it is usually associated, but not always, with crescents in the biopsy. And these crescents, as you can see, if there is more than 50% of glomeruli on a biopsy showing crescents, it is labeled as crescentic glomerulonephritis. And we discussed that any cause of GN can lead to crescentic glomerulonephritis. In a study published from AIMS in 2013, in 36 children with crescentic glomerulonephritis, almost half had immune complex GN, and the other, a little more than half had quasi-immune crescentic GN, of which they had ANCA associated as well as ANCA negative vasculitis. Among the immune complex, there were cases of SLE nephritis, PIGN, IgA nephropathy, MPGN, and HSP nephritis. At the median age was 34 months, and the renal survival was far better in immune complex GN. The risk factors for renal loss were oliguria and need for dialysis at presentation. A recent study on crescentic glomerulonephritis, though it is in the adults from South India, it showed that in the type 2 crescentic GN, where they have put all the immune complex diseases, they found that lupus was the most common cause of crescentic GN, followed by infection-related GN and also IgA nephropathy. In children who had normal complements, then anti-GBM, not children, sorry, in the adults with normal complement levels, anti-GBM disease, as well as ANCA-associated and ANCA-negative vasculitis formed a large chunk of those who had crescentic GN. So this brings us to a question. that are there any biomarkers in glomerulonephritis which help us answer the clinical questions that should we be biopsying this child early or can I wait? What will be the prognosis and whether our diagnosis is correct? And how aggressively should these children be managed, especially in terms of immunotherapy, immunosuppression, and whether they need any alternative therapies like eculizumab. So do the present biomarkers that we have, can they answer these questions that actually haunt a clinician? So in some diseases, some good biomarkers have been available. By good, I would say that they are sensitive, but are they specific? Are they validated? We really do not know. So galactose deficient IgA1 or antibodies to it have been seen in more than 80% of patients with IgA nephropathy, but there are no standardized ELISA testing for them. And it has been found that at least 40% of relatives of patients with IgA nephropathy also have these test positive for galactose deficient IgA1. So it may not be really a good biomarker for identifying the patients who require treatment. Similarly, a very common GN in our practice is the immune complex membranoproliferative GN due to various reasons, and there is no validated biomarker in this subgroup. C3GN, various biomarkers and autoantibodies by molecular testing as well as genetic testing have come up, and they are now being defined and refined for therapeutic purpose also. All this started with because the circulating phospholipase 2 receptor antibody levels were found to be highly sensitive and specific in adults with primary membranous disease, and they are being used to identify and also dictate the therapy. So that is why we are still looking at biomarkers and newer biomarkers to whether if we can decide the prognosis, confirm our diagnosis, and dictate therapy based on these biomarkers. So this is a list for biomarkers in nephrotic syndrome. It is outside the purview of this talk, but it tells us that there is a large list of biomarkers, but none of them have been really defined to be sensitive, specific, and have tests which can be tested and reproduced. Validated testing is not available. They have not been validated in large studies and do not correlate very well with the clinical course of the patient. Proteomics and as well as metabolic analysis, transcriptomics have been used. They are being derived in children. They have been used in children with steroid-resistant nephrotic syndrome. They are also being tried in glomerulonephritis, but so far it remains a research question only whether biomarkers can help us apart from diseases like membranous nephropathy in adults. With this, I would like to come to an end of my talk today on glomerulonephritis. And its assessment essentially is what I have attempted. I may have missed quite a few things, but I thought it is important to stick to an overview and give you a bird's eye view without boring my audience on a Saturday evening. Thank you, Dr. Kalaivani, and I would be happy to take any questions if there are any.
Thank you, Dr. Suprita. It was an elaborate discussion. Thank you so much. Next, we'll move on to the polling session. I request both the speakers to hold on to take up the questions at the end of the session. Dr. Hanif, sir, Dr. Suprita, please hold on. We'll be taking up the questions towards the end of the session. Now we'll be moving on to the polling session. We'll just go through few instructions for the polling session. All participants are requested to enter their proper email IDs and contact numbers during the process of registration for the ease of future communication. And we totally have 7 polling sessions, and the dates are mentioned below. And each polling session will have 10 questions, and it's mandatory to answer all the 10 questions to proceed with the submission process. And total duration will be for 8 minutes for the polling sessions, and you have 10 questions allotted for you. We will have star questions in each session, and star questions are taken into consideration in case of tie. And only the cumulative score of all 7 polling sessions will be taken as a final mark for selecting the winners. And we have 3 prize categories. And this polling session is meant only for the trainees and not allowed for the consultants. And request all the participants to log in on time using a bigger screen for easy viewing of questions. For better view in iPads and tabs, use landscape mode. Once you log into the webinar, you can avail the polling session in the same link during the webinar session. In case of any queries, you can contact our medical social worker, Mr. Joshua. Dr. Suprita, can we take up the questions?
Yeah. Dr. Kalaiman, yes. Can you hear me now? Yes.
Yeah, I'm able to hear you. I think we move on to the first question. We have a patient with a decreased consciousness, hemiparesis, hematuria, and nephrotic range proteinuria, and with an albumin of 2.6 and edema and a uremic lung. Creatinine is around 2.4, and the child has got AKI. ASTO is positive, but the patient is normotensive. How do we explain this case as ASPN? Hanif sir, Dr. Suprita, you want to take up the question?
Yeah, so we have the telltale markers of GN, definitely, that there is hematuria, there is proteinuria, the child has edema, the albumins are low because of ongoing proteinuria, and you can confirm on a biopsy, but as I can make out, the child is quite unwell at the moment. So you would there will be various reasons for hemiparesis in this child, including a venous thromboembolism. So you would need to work out on that, look at the stability of the child, and maybe you will need a biopsy to confirm once the child is more stable. It will be difficult to say whether the child is actually post-infectious or has any other reason for GN. And in this case, with a severe presentation, like we said, that it's almost like a RPGN, and it's very severe presentation, or if you can say it is an unexplained AKI, then these children do require, with these atypical features, they would require a biopsy. But stabilizing the child's condition is more important initially.
Okay, fine. Thank you so much, Dr. Suprita. And the next question is, how about toxic nephropathies due to drugs and heavy metals? Dr. Hanif sir, you're there?
Yeah.
This question?
Yeah, sure. The toxic material, the environment is one of the important cause of glomerulonephritis, particularly when you're using the different chemicals, industrial chemicals in the end. Besides this, some of the drugs also like hydralazine, they are also causes glomerulonephritis, and some of the drug causes interstitial nephritis. So drug is also causes either glomerulonephritis or interstitial nephritis. So particularly those which are industrial toxic and also the drugs. And is that a good question?
Yeah, so how toxic nephropathies due to drugs? I think that answers your the question. And the next question is, how long do you want to continue immunosuppression agents in lupus nephritis?
In lupus nephritis, is it immunosuppression? I think it's not part. It's a part of treatment, isn't it?
Yeah, yes. So their question is, how long do you continue immunosuppression or in lupus nephritis?
It depends on the
immunological activity.
Yeah, we have to go for the immunological parameters. It's guide you how patients is immunology composed. It look for the ESR, look for the complement levels, and other reasons. And you have to also look for the histopathological finding depending on the type of the histologically. So with this finding, you have to continue the drugs. Sometimes you have to continue for long times, particularly hydroxychloroquine. Sometimes you need to wait for a few years. And off and on, they may relapse, So in these cases, you have to put the child on additional steroid therapy.
Okay, Dr. Suprita, do you have anything else to add on?
So usually SLE will require very long immunosuppression, and like sir has already said, based on the clinical as well as immunological parameters. And these patients, children or adults, may have many flares. And as a child, especially the children, when they grow up, there is some hormonal influence also on the disease course. So yes, they're going to require very long immunosuppression.
Okay.
And we need to follow them and monitor them closely.
Okay. Thank you, Dr. Suprita. Like, next question is C4 reduced in PIGN?
Yes. So C4 is reduced in most cases of PIGN. There are about, in 80% of cases, C3 and C4 will both be reduced, but there are a few cases for which we cannot find any alternative diagnosis, and we end up putting them as post-infectious, but they may have, few cases may have normal C3 and C4. But C4 being classic is definitely reduced in SLE, so and in PIGNs.
Okay. The next question is, why always early morning urine sample? I think it is a very basic question.
Yes, so early morning urine sample will tell you is very important for all the biochemistries of the urine, especially protein and even the crystals and other biochemistries that we can do on urine. However, I already said that it may not be always possible in office practice to get an early morning sample being tested fresh, which is another requirement. So even a midday or any time of the day office practice, midstream clean catch is okay.
Okay. And the next question is acanthocytes. Can you please explain?
So on I already said that these are the dysmorphic RBCs that you see in urine in children with glomerular causes of hematuria. So these acanthocytes are nothing but ring-shaped RBCs or the distorted RBCs in the urine, and they have bleb-like protrusions on the surface. And about more than 20 to 25% of dysmorphic RBCs in urine are very, very sensitive for glomerular causes.
Okay, and the next question is proteinuria by urine PCR differs in different age group. Is it so?
Yes, definitely. So it is definitely there,
different age groups.
Yeah. Different age groups, but more than 2. A urine protein creatinine of when both are in milligrams, so protein and creatinine both are in milligrams per deciliter. So definitely more than 2 at any age group would tell you a nephrotic range proteinuria. And less than 0.5, we would not worry about so much.
Okay. And the next question is, how do you differentiate glomerular and tubular cause of proteinuria?
I think a lot of questions. No, yes, a lot of questions on assessment.
Differentiate glomerular and tubular cause of proteinuria.
So yes, so glomerular proteins would be different. We usually end up looking for albumin as the source when we are talking of glomerular proteinuria, and that is positive on dipstick. The tubular proteinuria will be smaller proteins and different proteins like retinal binding protein, low molecular weight proteins like like beta-2 microglobulin, the retinal binding protein. So they would be different, and their testing would also be different. We have not talked so much about it because it will be more in the purview of a talk on tubular disorders where you have these proteins in the urine.
Okay. And the next question is to Dr. Hanif, sir.
Yes, please.
When do you do biopsy in isolated microscopic hematuria? Is slit lamp examination and audiometry or routinely done for children with persistent microscopic hematuria or recurrent gross hematuria? Are we dependent on certain clinical findings suggestive of Alports to them?
Well, it's depend on the types of the hematuria, whether it's a glomerular hematuria or non-glomerular hematuria. First, we can go for the phase contrast microscopy. It's more than 25% RBC are dysmorphic. That time, there is indication. And continue for microscopic hematuria. Already, Dr. Kaldra, she mentioned about the, Suprita mentioned about the, how long it's about 1 year. And along with this, we have to combine some of the clinical findings, whether there is a of any involvement of the systemic involvement. So in these cases, there maybe we can go for the biopsy. And along with this, we can also correlate with the whether patient having the proteinuria or not. If there is proteinuria persisting, that may also another indication.
Okay, that answers the question. And the next question is to Dr. Suprita. In our practical experience, we sometimes get some patients who are edematous, but their BSU for albumin is negative. What would be the cause behind this? Will you please discuss?
What is BSU? Sorry, I don't understand this abbreviation. The urine assessment, maybe?
I think it's some patients they have used, even I don't understand, but their BSU for albumin is negative.
So, and maybe you can correlate with the serum albumin if the serum albumin is also normal.
Okay.
Yeah, blood serum, but I don't know, urine. So if the urine albumin is negative, you need to correlate with serum albumin, and sometimes it is our dipsticks which are maybe not, they're expiry, or they have caught moisture or something that they're not functioning properly, that we may get a false negative for albumin, and we must correlate it with the serum albumin. And there may be edema due to albumin losses, not only in the urine, but through the GIT. In children, it's a much rarer cause, but then protein losing enteropathies, or in very severe malnutrition. We see very few children with very severe malnutrition now, thankfully, but even then, kwashiorkor, which was earlier labeled as kwashiorkor, so severe protein malnutrition will also cause edema and other causes of edema. So we must not be just, thinking of kidney as the cause of low albumins and edema. So cardiac causes, there may be hepatic causes. So we need to correlate completely to see what is really happening.
Okay. And we are running short of time. We'll quickly through the questions. Is that RPGN would become a manifestation of other GN such as infection or HUS?
Yes.
Yeah. It's a RPGN is the manifestation of other disease like lupus, like Henoch-Schulin purpura, or ANCA. It's a manifestation of the other diseases secondaries happen. Is that the right you want to say? Yeah.
Thank you, sir. The next question is patient with diarrhea, negative HUS, and factor H is found to be low. He has normal urine output. When can we switch from FEX to plasma infusion? He now has complete hematological and renal remission after 21 days of FEX. And what is the frequency of plasma infusion needed?
I think we should leave this question for a talk on HUS.
Yeah.
It will be better to discuss
too much into the depth of HUS.
Yes, so we'll discuss it better when you.
Yeah. I think along with this, we have to know the cause of HUS because if there is a pneumococcal infection, particularly in these cases, plasma or other infusion is dangerous. So you have to also look at it. So we have to leave it for the next session in the HUS ceremony. Yeah,
we have specific topics in the upcoming sessions, which will be covering the whole of HUS. So we'll be taking up the questions on that specific day. And the other question is, why IgA deposits systemically in some patients or only renal deposits in some other patients?
Sorry, can you repeat it again?
Why is that IgA deposits systemically in some patient or only renal deposition in a few other patients?
Yeah, I have mentioned about that. What's happening in the basic pathology is the position of the IgA is that there is a defect in the glycosylation. So there is a deficiency of the galactose. This causes more sticky hemoglobin A. So what's happened, they can also deposit in case of, I have mentioned about it, there are some studies that have mentioned that IgA also found in the normal skin when they go and biopsy. So still, so we are not sure about, not exclusively is it present in the glomerulus, but also not in the systemic. With this study, it's very difficult to say. But basic defect is there is a sticky IgA level. Along with this, when there is a formation of antibody, this easily precipitate in glomerulus because there is a filtration to glomerulus. But there is also present in the basal wall.
Okay.
Yeah.
Thank you, sir. And the next question is, I think it is pertinent to HUS. We'll have this question for the day of HUS discussion. Next is, it is just an information. We were wondering what BSU is. It is bedside urine test. And the next is there any difference in percentage of dysmorphic RBCs in urine in neonates and pediatric age group? If yes, then what is the significant percentage of dysmorphic RBCs in neonates?
So neonatal GN will be very, very rare. There are hardly any causes of glomerulonephritis in newborns. Their causes of hematuria will be different, and they'll be more like renal vein thrombosis, maybe abnormal coagulogram and things like that. So I am not particularly, I have not come across a number or a percentage which would be significant in newborns and if there's any difference, but it's very rarely described. Very, very
yeah,
rare.
Usually what is described is how do we differentiate the glomerular and the non-glomerular counts. Less than 20% becomes non-glomerular, more than 20% becomes glomerular. But the age group we haven't come across. And the next question, I think we are done with the questions and being I think we are done with the questions. Namalva sir, do you have anything to add on? Namalva sir is there online or probably sir has left? Thank you so much. It was an excellent discussion, Dr. Hanif sir and Dr. Suprita. Thank you so much. It was really a great discussion on covering all the clinical and the laboratory investigations which is pertinent to glomerular disease. Thank you.
Thank you so much for inviting me.
Thank you, Dr. Suprita.
Thank you. Thank you so much, Professor Hanif.
Yeah, okay then. See you. Good night.
Thank you, sir. Take care, sir. Good night, sir. Take care.
Good night.
Good night.